Good evening, everybody. Thank you all for joining us tonight. I'm Hannah Collins, and we're here with Dr. Powell discussing bladder cancer. I'm going to go ahead and introduce him and then let him begin starting his presentation. Dr. Christopher Powell received his undergraduate degree from Valdosta State University before obtaining his medical degree from the Medical College of Georgia in 2010. His surgical internship, urological surgery residency, and chief residency were completed at the University of Kansas Medical Center. In August 2015, Dr. Powell moved with his family to Carrollton and joined West Georgia Urology. A longtime Georgia native, Dr. Powell was happy to return home. He currently performs robotic surgery for West Georgia urology patients, and a large component of his practice is dedicated to the treatment of urologic cancers. Dr. Powell, you can go ahead.
Thank you very much for the introduction. I'm going to go through this PowerPoint slide presentation that discusses bladder cancer, and we'll have time for questions here at the end. You can see on this screen here how to ask a question at the end, and I'll be happy to do my best to answer your questions. But the first thing I'm going to do is go through a few slides about the bladder and what bladder cancer is, and hopefully give you a short overview that allows you maybe to understand it a little bit better, what it is, how we diagnose it and treat it, and some of the unique tools that we have here at Tanner. So first off, the bladder is a hollow organ. It's located in the lower pelvis. It has flexible muscular walls. They stretch to hold urine at low pressure and then squeeze to send urine out of the body. And its primary job is to store urine, which is some of the waste of the body, and then empty that at a low pressure. When cells that make up the urinary bladder, they start to grow, and they can grow unchecked, they can turn into cancer similar to any other type of cancer. One thing that's really important for people to understand is that the most common cause of bladder cancer is painless blood in the urine, or you may hear me reference it as hematuria. That's just our fancy word for blood in the urine, and that can mean both what we call gross hematuria, which is blood in the urine that you can actually see yourself, see it in the toilet, or microhematuria, which is blood in the urine that is picked up on a special test called a urinalysis, or something called urine microscopy, which is where we look at urine under the microscope. But a lot of folks think, oh, I feel fine, I don't have any symptoms, that's not a big deal because there's no pain associated with it, or I'm not I don't have an emergency or fever or anything like that. That's not okay. Anytime you see blood in the urine, that is maybe not an emergency, but it's certainly urgent that you be evaluated for that, because even if it's not bladder cancer, blood in the urine is not normal and should be evaluated. Some symptoms which patients might have with bladder cancer would be difficulty urinating, low back pain, loss of appetite, weight loss, or feeling tired or weak. Not everyone has these symptoms, and in fact many people do not. Like I said, most people just have a little bit of blood in the urine that they may not even be able to recognize. They may need their primary care provider to identify that for them. Oftentimes when patients have really significant symptoms, including systemic symptoms such as weight loss, if it's associated with a cancer, and it's not always, but if it is associated with a cancer, that's normally fairly advanced, and so you certainly want to check it or identify it before that. So there are lots of different types of bladder cancer. When we talk about bladder cancer as urologists, for the most part, we're talking about urothelial cell carcinoma, which is what that picture is right there in the bottom. That is what we call a papillary bladder cancer. It looks a little bit like maybe a sea anemone or a sea creature. That's normal bladder on the edges of the picture there, and right in the middle, that lesion is urothelial cell carcinoma. It's by far the most common type of bladder cancer. It's the one that, and I'll go into this a little bit later on, but it's the one associated with smoking, and it is what we're really talking about when we talk about bladder cancer. Now there are even more variants than I listed here, but these are again just some of the more common ones. Squamous cell carcinoma of the bladder is a bladder cancer that you can get from chronic irritation. So maybe a bladder stone or a long-term indwelling catheter or recurrent infections or those types of things can cause squamous cell carcinoma. There are some really rare international causes of that, but again, that's very uncommon. And then adenocarcinoma is a type of bladder cancer that people will occasionally get if they have congenital remnant. So basically a urachal anomaly that should have gone away when they were younger. Sometimes they'll have a little bit of cancer in that. All very, very uncommon. And by far urothelial cell carcinoma, that first one, is by far the most common type of bladder cancer. All right, so risk factors of bladder cancer, certainly smoking is hands down the biggest risk factor. A lot of people associate smoking with lung cancer. I think there's been a lot of marketing towards that, and people understand that smoking and lung cancer go hand in hand. It makes sense. But bladder cancer is a common problem associated with smoking. It's by far the biggest risk factor. Family history, long-term Foley, like we talked about, squamous cell carcinoma, previous pelvic radiation. This has improved over time, but certainly about 15 or 20 years after some sort of form of pelvic radiation, there is a risk of a slight increased risk of bladder cancer or secondary malignancy. So certainly important if you've had radiation in the past and have new symptoms such as blood in your urine or signs such as blood in your urine that you're evaluated. Again, it could be a totally benign reason, but needs to be evaluated. All right, so bladder cancer begins in the innermost lining of the bladder, what we call the mucosa, and I'll show you a picture on the next slide. As it grows, it tends to grow from the inside towards the outside, and as it grows towards the outside of the bladder, it penetrates more layers and becomes more advanced. And if left unchecked, it could grow all the way through the bladder and invade nearby structures in men, such as the prostate. So this is a good schematic that gives the different, what we call T stages. And the first one there is TA. I'm going to skip CIS because that's a different issue altogether. But TA is a superficial bladder cancer. You can see there that it just is sitting right on the lining of the bladder. And then you have T1, which invades slightly more tissue into the bladder, but not yet into the muscle layer. T2 is muscle invasive, and that's when treatment options change. So if we catch somebody that has bladder cancer and we identify it when they are TA or T1, which basically just means not invading into the bladder, we have a lot more treatment options, a lot less radical treatment options that offer a cure. Once it invades into the muscle, you have to be very aggressive with how you treat bladder cancer in order to prevent it from spreading. T3 is beyond the muscle and into the fat there, and then T4 is into the surrounding structures. So how do we find bladder cancer? Well, our initial evaluation, if you were to come into the clinic with blood in your urine, there's a very standardized evaluation that everyone should have. And it's a guideline made by the American Urological Association, the AUA. And we all use this, whether you see a urologist in Georgia or you hopped on a plane and saw a urologist in California and have blood in your urine, everybody should be doing the same thing. One of the first things that we'll do is send your urine for something called cytology. We'll send it looking for cancer cells in the urine. That is very good at identifying aggressive high-grade cancer, not so great at identifying low-grade cancer, but it's a tool that we use, urine cytology. Oftentimes, if you have blood in your urine, we should get a CAT scan or an ultrasound to look at the kidneys, the ureters, which are the tubes that drain the bladder, and then the bladder itself. That's really looking for non-bladder cancer causes of blood in the urine, whether it's kidney stones or bladder stones or maybe an enlarged prostate with somebody who has chronic blood thinner use, kidney cancer, those types of things. You're looking for non-bladder cancer reasons. But and then the last thing that most people should have is cystoscopy, which is where we use a small camera like the one on the picture here, and we go up through the tube that you pee through and put that in the bladder and look around the bladder it's a cystoscope that gave us that picture that we saw earlier of the bladder cancer. That came from a cystoscope. There's what we call white light cystoscopy, or sometimes we'll just say cystoscopy. And then there's blue light cystoscopy, which is a very cool new product that we've had at Tanner here actually for a few years that helps us identify hard to see bladder cancers. And I'm going to show you that here. So blue light cystoscopy, like I said, is the latest and greatest that we have. If you look on the left, there are pictures of white light cystoscopy and blue light cystoscopy. On the left, you can see that there's something going on that cystoscopy. The tumors they don't quite jump out at you. If the urine was a little cloudy, if there was a little bit of blood in the urine, you might not be able to see things even that clearly, and it's easy or possible to miss tumors in the bladder. On the right there is an example of blue light cystoscopy. Now what we do is we put a substance in the bladder called Cysview, and that substance sits in the bladder for anywhere from 1 to 3 hours prior to the procedure. And then we drain the bladder, we put the special camera in, and it makes cancer glow, essentially a fluorescent pink, while the remainder of the bladder, the normal part of the bladder, is blue. And so it makes identifying very small bladder tumors or very flat bladder tumors much easier. And one of the important things about treating bladder cancer is, like we said earlier, getting it before it grows into the muscle and getting all of it. So if we go in and we take out 90% of it, but we leave 10% of it accidentally or without being able to identify those other areas, then of course it's going to grow and come back, and we'll probably identify that at the next surveillance cystoscopy. But the more you can get of it, the better chance of cure you have. Bladder cancer, like some other cancers, has a tendency to want to come back, even if you get it all, even if it's not invasive, even if you do everything you're supposed to. There's still a fairly high rate of recurrence. So it's especially important that you catch things as early as you can, you identify all the tumors, and that you treat them all as early as possible. So what are those treatment options? Well, the first step whenever we identify a bladder cancer is to remove it utilizing a technique called transurethral resection of bladder tumor, or TURBT. That's a picture on the right of or a schematic of a TURBT. We use that loop that you see in the top and the bottom picture. It's connected to a cautery device, and it's very, very, very hot. So it cuts and cauterizes at the same time to minimize bleeding. And we scoop it out kind of like an ice cream scoop. And the goal there is to remove the tumor. As you can see on the bottom picture there, those dotted lines would be maybe successive swipes. The goal is to remove the tumor in its entirety, to get all the way below the tumor and get some normal tissue with your resection, so that our pathologist can be sure that we got everything. If we just get the tumor, then it's hard to tell how deep it invades. What you want to do is get lining of the bladder, probably even muscle if you can, without poking a hole all the way through the bladder. That way you can tell the depth of invasion, which, like we talked about earlier, determines treatment options. So there's surgical treatments, like we said, transurethral resection of bladder tumor. Everybody that has a bladder cancer identified should have that done to begin with, because that helps you stage it and offer other treatment options. Cystectomy would be the most aggressive, most advanced treatment that you could have for muscle invasive bladder cancer. Again, this is like we were talking about. Once it grows into the muscle, bladder removal is on the table as a treatment option and should be strongly considered. If you catch it before it grows into the muscle, most of the time you can avoid that. But very few people with bladder cancer ends up having to have a cystectomy, but it is on the table for aggressive or advanced bladder cancer. Some of the other options that we use that are non-surgical are things called intravesical treatments, and we do those in the office. Intravesical means in the bladder, so it's a immunotherapy or a chemotherapy that we put in the bladder. And when I say chemotherapy, I'm not talking about what most people think about when they think of chemotherapy, of being sick and having issues with nausea and vomiting and hair loss and those types of things. This is a chemotherapy that only affects the inside of the bladder, the lining of the bladder. One of the benefits of the types of treatments that we use is that they're not absorbed by the bladder, and the bladder doesn't absorb them, and so they're not processed systemically. They don't go through your body. They only affect the lining of the bladder. They only affect the part that they touch and nothing else. BCG is basically a dead tuberculosis type treatment. It's an immunotherapy that revs up your body's own immune system to treat bladder cancer. And mitomycin C is a type of chemotherapy that we can put in the bladder after TURBT to lower the risk of recurrence. All of these things are designed to lower your risk of recurrence and your risk of progression. What I mean by that is the cancer getting worse. And then certainly at Tanner, we have a great multidisciplinary approach. We meet about every week, certainly multiple times a month, to discuss all new urology cancer patients, to make sure that the urology team, the medical oncology team, the radiation oncology team, oftentimes radiology, pathology, care coordinators, that we're all on the same page optimizing patient care. So robotic cystectomy, this is, I'll just have a quick aside on this. This is not something that we're currently doing here. It is another way that you can use the robot. It's a way to remove bladders. It allows for smaller incisions and can shorten patients' recovery time. The vast majority of patients that are diagnosed with bladder cancer are not going to have their bladder removed, especially if we catch it early. And they're going to benefit from some of those other treatment forms that we do have here, blue light cystoscopy, in the bladder, intravesical treatment options, and TURBTs. All right, so how do we prevent it? Well, number one, don't smoke. I think that that's pretty common knowledge these days. But if lung cancer is not concerning enough, maybe bladder cancer is. Don't smoke. It significantly lowers your risk. If you're in a workplace where chemicals are found, make sure that you're doing what you're supposed to do to limit your exposure. Wear the correct protective equipment and things like that. Drink plenty of water. This is more to limit your inflammation in the bladder, limit your UTIs, those types of things. And then certainly, I think one of the most important things that you can do is make sure that you have an appointment with a regular doctor, a primary care doctor, who can do the basic health screening tests, like testing your urine to make sure that there's no blood in there that you can't see. Again, that microhematuria term, to make sure that there's nothing concerning in your urine that needs to be further evaluated. So certainly surviving a diagnosis of bladder cancer is exciting and stressful. It's very, very important, like I spoke about earlier, that you maintain appropriate follow-up, because bladder cancer, even if it's not the life-threatening kind, even if it's not the initially aggressive kind, it does like to recur. And so regular maintenance cystoscopies, so looking in your bladder with a camera, we do for most patients, oftentimes on a setup of about every 3 months, sometimes less frequently for low-risk patients. But urine evaluations, regular cystoscopy, and then sometimes maintenance treatment. Sometimes with bladder cancer, you feel like you're playing a little bit of whack-a-mole, that you'll have a tumor come up here or there. That's low risk, it's non-invasive. You scoop that out. You check them again in 3 months, and maybe that's clean, and then you check them again in 3 months, and maybe there's another small lesion, and that can get tiresome for patients. But it's much better than the alternative of aggressive and muscle-invasive cancer. So there are approaches that we can use to limit treatment and limit progression. It's super, super important that you keep your follow-ups. This is not a one and done type of treatment. And then ask your doctor certainly for a care plan, diet, physical activity suggestions. Making sure that you're eating as clean as possible is probably good for any type of cancer. And then again, keeping primary care appointment. Okay, so hopefully that gives you a little bit of understanding about what bladder cancer is, how we diagnose it, how we treat it, what are some of the newer technologies that we have here, like blue light cystoscopy, and our new TURBT equipment, and I would be happy to answer any questions that you guys have. Thanks for listening.
Dr. Powell, you did have a couple of questions come through.
Okay.
One was, do you have to be referred for blue light?
No, you don't have to be referred for blue light. I mean, you're seen in our clinic and we feel like blue light would be a good option for you. Based on your history and based on the conversation that we have, we can certainly do that. You don't have to be specifically referred for blue light. I don't know if that's referred out. We certainly do that here, but you don't have to specifically be referred to our clinic either for that to happen.
Okay, and another one was, if I'm worried about managing the cost of cancer care, who can I go to for that?
Yeah, I know Tanner has a lot of resources designed to make sure that we make it as reasonable as possible for patients. We're certainly not going to refuse cancer care based on cost, but we have lots of resources to make that more manageable. And I would say we'll try and get a more specific answer for you, but certainly we deal with those issues all the time in our weekly cancer meetings about trying to make it as accessible as possible.
Someone also wanted to know if there were bad side effects with radiation therapy that they needed to be aware of.
Yeah, I think any treatment has side effects. As much as we'd like to be in an age where we treat some of these aggressive or treat any cancer without side effects, I think everything that we do causes side effects. Even the TURBT that I mentioned earlier will have short-term side effects, urinary urgency and frequency, and maybe some blood in the urine, and maybe a higher risk of a UTI, that kind of thing. Our goal is to manage those side effects as best as possible, knowing that we're probably going to have side effects, but the trade-off of cancer, hopefully cure, is worth those side effects. Radiation certainly has side effects. Oftentimes, specifically for radiation, those side effects are somewhat delayed, meaning you don't necessarily have side effects right away, but over time maybe you have some blood in the urine that's not because of cancer, but because of the inflammation from the radiation, maybe some urinary urgency or frequency, those types of things, yeah. But certainly it does have side effects, but again, all of this is risk-reward type thing, and there's no one-size-fits-all when it comes to bladder cancer treatments. One thing that we do here at Tanner in our meetings is we use something called NCCN guidelines, which is National Comprehensive Cancer Network. So everybody is treated based on a algorithm that has lots and lots of science behind it, lots of clinical trials, lots of patients that show that these treatment algorithms work. But even within those guidelines, there are options. So one person may choose, if they have advanced bladder cancer, for instance, one person may choose to have their bladder removed because they've been counseled about the risk and benefits of that and the side effects and the potential complications and the potential benefit. Another person with the exact same disease may choose to have bladder sparing therapy, where you get chemotherapy and radiation and periodic TURBTs or bladder tumor resections, because they prefer the risk and the side effects to that treatment modality more than they do having their bladder removed. So there are side effects for almost everything we do. We try to have an informed conversation with our patients and make sure that they understand what they're getting into and what the benefits and the risk are, and then use good algorithms that allow patients to make some of their own choices, but understanding that there are side effects associated with it.
Sure. And you had another question, which was the last one, is your practice taking new patients?
Yeah, absolutely. Yeah, for sure. Our waits are not very long. I mean, I normally don't have patients wait more than about 2 or 3 days to see me. And the reason, unless I'm in surgery, but again, it should be less than a week. But And the reason for that is a lot of what I do is cancer care, and so we don't want to have patients waiting a week, 2 weeks, 3 weeks, a month with concern about whether or not they have cancer or maybe have a cancer diagnosis and need treatment options. Yeah, we're definitely taking new patients, and the wait is not what you would expect maybe for a practice.
All right, Dr. Powell, well, thank you so much for joining us tonight.
My pleasure. Thanks for having me.
And thank you everyone for joining us also on this webinar. Please continue to check out our classes on tanner.org/classes and events for other informative topics that we have coming up. And I hope you all have a wonderful evening.